Thank you. I'm very happy to be here in Taiwan for my very first time here and to attend this wonderful meeting. And I also wave you on behalf of my society, TSCRS. I will talk today about results with the intensity IOL I came in touch with a few years ago, experiencing the advantages of this IOL at that time. Should this progress? Yeah, this is my financial disclosure. I think you already heard about optical property of conventional diffractive IOLs, the way that the intensity IOL is organized, giving us 5 foci. And one important thing of this IOL is that the refractive focus is the intermediate focus. However, most of the light is directed onto the distant focus that is diffractive in nature. So this will will influence the way we measure vision in the post-op, and maybe we will discuss that after my speech. We heard we have 5 foci now that probably will give us a flat defocus curve. So I was interested in comparing this lens with the other lens I'm experienced with, that is the... Should this progress? Yeah. And we already heard about the target, the US Air Force, and how it is with the 3 millimeter and 4.5 millimeter pupil, and the point spread function. So how should we compare the intensity with the fine vision? That's the gold standard of trifocal lenses. The 2 lenses we are talking today about are similar in nature, but very different in the optical design. They both are diffractive lenses, but the PODEF is apodized. The intensity has a different type of light utilization. The addition to the refractive power for the PODEF is plus 1.75 and plus 3.5. For the intensity is minus 0.75, minus 1.5, plus 0.75, and plus 1.5. The IOL size is different, the optic size is the same, the material is roughly the same as for the water content. The spherical aberration is not that different. However, there is a difference in the number of the rings, because the PODEF has 37 rings, diffractive rings. The intensity has 12. I don't know how the engineers from Hanita lenses were able to design this lens with only 12 diffractive rings, but they did. This study was made with 30 patients per group. They were cataract surgery or refractive lens exchange. The axial length was limited, 21 to 26 millimeters, and astigmatism was also limited. 1 diopter, up to 1 diopter if with the rule, and up to 0.5 diopter as against the rule, because no toric lenses was used here. The patients had to be free from other ocular disorders. And we studied refraction, visual acuity, the focus curve, contrast sensitivity, aberration, and symptoms. And the 2 months we visit was considered here. Most of those patients had surgery performed in both eyes on the same surgical session. These are the parameters we found at surgery. Patient age was roughly the same. They were about 70-year-old with a huge standard deviation, because a few of them were operated for refractive length exchange. The K reading was roughly the same, the axial length was roughly the same, the ACD was roughly the same. The IOL power was not, because of the different A constant of the two IOLs. I used 118.2 for the intensity, the model I received. I used 119 for the PODEF. These are the results in terms of spherical equivalent, and there is something to say about the objective spherical equivalent, because with the intensity IOL, the auto-refraction usually gives a myopic refraction of a little more than 1 diopter. With the trifocal, it was a little more than 0.25 diopter. At the beginning, I thought that this came out of the fact that the autorefractors picked up the refractive focus of the intensity. But later on, I found that this was not the case. It seems that whenever an intraocular lens has a diffractive part, this diffractive part will give a myopia at autorefraction, but we can discuss this later on. The subjective refraction was not that different in terms of diopter between the two groups. However, the difference was statistically significant. The difference was not existing as in the cylinder, in the post-op astigmatism, both in absolute cylinder, absolute manifest cylinder, and in astigmatism when reported to 0 degrees or to 45 degrees as the oblique astigmatism is considered. This is the subjective refraction. The categories, most of them were within 0.5 diopter of the intended refraction of emetropia. A few of them were a little bit outside that. With diffractive lenses, we should avoid myopia, because patients will complain about distant vision that's not enough for driving, for instance. As you may know, in Italy, we drive in a crazy way. In Taiwan, almost the same, I saw. Anyway, if we have a slightly hyperopic refractive outcome, patients will be satisfied with distant vision, and they might complain with close near vision, but this is something they can accept more. So if we implant a diffractive lens, we should take the first hyperopic value as reference out of our formula. The contrary, when we implant an EDOF lens, when we should keep the first myopic. That's important to avoid post-operative dissatisfaction. These are the visual acuity results in terms of the amount of visual acuity. There were a little difference in the uncorrected distant visual acuity in favor of the intensity, but this was very, very low. So I don't think this is important. Corrected distant visual acuity also was not that different, though it's true this lens gives little better distant vision than the PODEF gave it in my patients. The difference is huge in the intermediate visual acuity. We got 0.03 logmar instead of 0.11 with the PODEF, and this is a difference that's appreciated by patients. With my PODEF patients, a few of them complains with computer vision. You know that now the common clerk has 3 computers at different distances, one large computer in the center and 2 small computers on both sides. And they want to see sharply all of them. They can't get them with the intensity they could. With the PODEF, it's a little bit more difficult. And there were no differences in near visual acuity. So out of these slides, I understood that the intensity gives a flatter the focus curve and better visual acuity than the PODEF. These are the categories of uncorrected visual acuity, and definitely the results were a little better with the intensity than with the PODEF. And this is the focus curve, and this is probably the most important slide of my talk and all the talks about multifocal lenses. Because when we see such a flat the focus curve, we should keep in mind two things. First, we are successful. We are providing the patients with full range of vision. Second, we must be careful because they will have 20/20 uncorrected distant vision through all the flat the focus curve. So we should refract those patients in the post-op as if they are accommodating. So we will pick up exactly the subjective refraction where it is, and we will understand the range of vision they have and the accuracy of our power calculation. If we only think, ask the patient, can you see well for distance? They will always answer yes. But then we should check when this distance vision falls within the range of full vision they have within the flat the focus curve. Let's try again. Great. Contrast sensitivity was not different in my study, in this study between the intensity and the PODEF, but this was only the photopic contrast sensitivity. And so maybe with a better, this was measured with the optotype in photopic conditions. So maybe with a better accuracy, a difference might be elicited. Then I was interested in the optical aberration, and the optical aberration was measured in this study with an Hartmann-Shack sensor. We know that the Hartmann-Shack sensor is not the best way to measure aberrations with diffractive lenses. Now I received another aberrometer called the pyramidal aberrometer. I will check them again. However, the point is that the Hartmann-Shack sensor is not enough good to measure the diffractive lenses. However, I was looking for a difference. And so I measured the high order aberration total, and this is the absolute value. The comma, Z3 minus 1, Z3 plus 1, and this also is an absolute value. And the Z3 minus 3, this is trifocal, this is trefoil, and Z3 plus 3 again trefoil, and Z40 spherical aberration. The spherical aberration was what we could get from those two lenses. It was consistent with the value, the basic value provided by the manufacturer, but we had not perfect results with the Hartmann-Shack sensors, although the overall high-order aberration was similar with both designs and was low, not affecting the clinical results with those lenses. Let's go on. I also have an OCAS aberrometer, and I was looking for the difference, if any, with those two lenses with the double pass aberrometer. You know that the Hartmann-Shack will give you if the building is straight or deformed, but the OCAS will give you the idea if there is fog preventing your vision. And I also had contradictory results here, especially with the cutoff degree. The MTF cutoff is the value of MTF where the patient will see gray instead of white and black stripes. And this was a little bit lower with the intensity, a little bit higher with the trifocal. And this is something we still are investigating according to the result we had with those two lenses that are similar in the concept, but very, very different in the optical design. You know that the McAlinden questionnaire is now the most used questionnaire to investigate symptoms in the pseudophakia or visual symptoms in general. The questionnaire divides symptoms frequency, symptoms intensity, and symptoms bother. And there are several answers the patients have to give for us to investigate glare, halos, starburst, hazy vision, and so on. And we found differences with better results for the intensity with halos and starbursts as for symptoms frequency and also fluctuation of vision. If we go on to symptoms severity, also we keep up that glare and halos are better, starburst is a little bit better, while in the other parameters we found no difference between groups, that is, between lenses. When you go to symptoms bother, we see that differences are a little bit higher, and glare, halos, starbursts are definitely better with the intensity. Hazy vision, blurred vision, distortion a little better, fluctuation much better. So out of McAlinden questionnaire, I had the impression that not the impression, I had the certainty that the intensity is better accepted by patients than the PODEF. Then, after having the subjective part of these symptoms, I was interested in finding the evaluation of a halo, and these are results with 3 years of follow-up in a different subset of patients. I tried the Zeiss Halo and Glare test that's free, available on the web, and this was administered at various times after refractive lens surgery and done on the original study I did with the intensity a few years ago. So this study includes 60 patients with a pentafocal and 73 patients with a trifocal. And this is what we got. This is the cumulative results as for the halo size. So all patients together, the halo size is reported as the type 2 halo. Type 2 halo is a sort of halo with a starburst. And this is typical of diffractive lenses with this test. And the size was reported, as you see in this slide. The interesting to see that even after 3 years, the size of the halo is similar as the size of the halo after 1 month. So it seems that the size of the perceived halo with this test does not decrease with time. Great. Also, the halo intensity is roughly the same with variations, but definitely we cannot say that the intensity of the halo as measured with this test decreases with time. It doesn't happen. Patients are satisfied, patients are not disturbed by the halo, but the halo, if we look for it, is there, and this is obvious because the lens is there. The halo is produced by the optics of the IOL, so we cannot expect the halo, when we look for it and we measure it, to fade with time. The symptoms do, the halo size apparently doesn't. Let's go on. Are there differences between IOLs? I couldn't find any great difference between the two IOLs. When we compare the pentafocal with 12 rings with the trifocal with 37 rings, I was expecting a lot of difference, but there was not. Probably because the halo depends on the optics of the IOL, on the number of foci, on the light that's directed onto the different foci. So this is more objective than the symptoms of the patients, and so these were the results. Also, for the intensity of the halo, there were no huge differences between the two groups of IOL. And this is also consistent with the previous results we had. Then I asked the patients, can you drive? Do you have difficulties because of the halo? And they said always, very few patients, less with the intensity than with the PODEF, but very, very few. Sometimes similar numbers, and never. Never was the main answer. So it seems that the halo induced by our lens, by our diffractive lenses, stays with time, but patients don't perceive it as a problem. This is consistent with the previous studies from our friend in Portugal, Professor Murta, who demonstrated with functional MRI that the patients get accustomed to the halo of diffractive lenses during the first months, and then they don't perceive it, they don't care for it. However, when you look for it with the Zeiss simulator, we still are able to find it. What results I got from my clinical practice? With the quantitative results, halo is more perceived than glare, and type 2 halo with starburst is perceived with diffractive IOLs. Other results, no difference between diffractive IOLs, no change over time with few exceptions, no influence by axial length of power, no influence by optical corrections, because this was one of my first questions. Does the optical correction of residual defect improve halo? It doesn't. And the question results gave me the result that there is no relation with driving difficulties. So with diffractive IOLs, the size of the halo depends on the dioptic ad. The type of the halo depends on the IOL optics. The number of rings has no role. Fine optical correction is useless. The halo does not fade with time, but psychology is the main driver of patient satisfaction. For this reason, now I tell all my patients candidated to full range of vision who ask for full range of vision that the halo will be there. I show them the Zeiss simulator, and I tell them this will not affect your driving, but you will see and you will perceive this halo for the first month. What can we conclude out of my experience with the intensity IOL? The pentafocal intensity IOL was effective in removing the need for optical correction in my pseudophakic patients. It always works, and it always works in a very good way. It always gives patients a full range of vision. They can read fine print easily. And the visual acuity obtained with the distance diffractive focus was as good as that with the refractive distance focus of the PODEF, or even better. The near vision was similar, but the intermediate vision was definitely better than that of the trifocal IOL. What about the optical quality? I found no difference in photopic contrast sensitivity between IOLs, no difference in with the Hartmann-Shack aberration, with the limitation of this sensor in measuring diffractive optics. A difference was found with the OCAS aberrometer, probably due to the diffractive character of the distant focus of this IOL. What about dysphotopsia? No increase of dysphotopsia and unwanted optical phenomena with pentafocal intensity as compared with trifocal, with some advantages for the pentafocal about patients' symptoms. While I thank you for your attention, I was inviting you to Copenhagen to our TSCRS Congress in September, if you can. Thank you.
Thanks for Roberto give us so many information about the intensity, and I'm so surprised that even during the driving issue, he can still put intensity in this kind of patient. Because for me, I always ask my patient, do you have night driving? If you have night driving, then I may abandon the diffraction type IOL for this kind of patient, because I'm just afraid of the halo, glare, this kind of symptom and sign. Okay, so it looks like this IOL give us a new insight about the diffraction type of IOL, because it's not just 3 focus, 5 focus, just like enhanced the trifocal become a very wide range EDOF. So is there any question from the audience? Want to give us a question about intensity for our very international speaker? Yeah.
Okay, thank you. So that's a very good presentation. I would like to know how you quantified the photopic symptoms. Photopic, the glare, halos, starburst. So how did you quantify those?
There is the ZEISS test that's free on the web. It's not so easy to find it, but it's free on the web. And the patients they have the mouse, and with the mouse they move the cursor, and they tell you the size of the halo, and they tell you the intensity of the halo. So they do. I don't quantify. And then you click a button, and the display will give you the numbers. The numbers are hidden while the patient is moving with the mouse, the cursor.
Apart from the halos and glare, starburst, you have a different software for it, or you have a device that measures it?
The ZEISS test has 2 types of halo. One is the simple halo with no starburst, and the second is the halo with starburst. You can't divide in the second type. The second type is the type they go to with diffractive lenses. And you can't divide the starburst from the halo with that device. It's just one. The cursor will increase both sides.
Thank you for your answer.
Actually, using with the ZEISS glare, usually the patients are very old. In case of the patients are moving the scroll, the old parameters, and the measuring several times, the patients report several outcomes, different outcomes. So do not believe those Z-square hollow simulator many times, much more. The only depends on the patients reported the most objective outcomes. That's not so good. So, doctor, I'm not so good in the dark situations or night driving. It's very dependent. Yeah.
I have a question. Thank you very much for a great presentation for both of you. Pentafocal design is really interesting design because for far focus, it is using the negative second diffraction order. But if you can imagine, like for far focus, there should be a chromatic aberration effect. So have you ever experienced from your own patients about those chromatic aberration effect? Like, for example, it is based on the green light, but if you have certain circumstances like blue light or versus red light only situation, is there any issue with that or not?
I didn't measure this directly. I can give you two comments. First, the PODEF has a version with correction of the chromatic aberration in the distance and the intermediate focus that worsen the chromatic aberration in the near focus. They called it the PODEF Triumph. I tried it. I found no advantages. And later on, the company discontinued it for several reasons. Second, there is now evidence that the size of the halo and the size of the starburst depend on the band width of the incoming light. There are a few very, very recent studies that tend to demonstrate that with the artificial light in internal environments, that's more and more has narrow bandwidth that might influence vision with diffractive lenses in different way. These are new findings that will probably elicit more research in the near future.
Oh, yeah, that's very good questions. Actually, I didn't measure the chromatic elevation of the pentafocality. However, it is maybe very different from the conventional diffractive lens because of it uses the negative order diffractions. So maybe there are some difference between the conventional diffractive IOL, but I didn't measure, and I don't know how to measure the chromatic aberrations of the diffractive IOLs. And also the patients' reported outcome was now very usual with the other conventional diffractive IOLs. They doesn't complain about the blue light or more red light about that. Yeah, very usual.
Is there any question from audience? No, I just will ask one question about the final autorefraction result. That what is the ideal amount? Means that you put the patient in front of the autorefractor. What the power is the best for your patient implant the intensity?
Yes, always tricky situations. Using the autorefractor to measure the patient's refractive status is very difficult. So I usually the subjective manifest refractions. Yeah, that's it. I don't use the autorefractor as a result.
I do, because it's easier for us to rely on data obtained with the autorefractor. I use the Topcon autorefractor, an old model. I found that minus 1.25 is the usual outcome with this lens when the patient is perfectly ametropic. There are other lenses, diffractive lenses, that provide not similar but myopic results. One is the Rainer, that was measured up to -2. And the other is the Symphony, that was measured minus 0.5 to minus 1, it seems that every time we have a diffractive part in the intraocular lens, the automated refractor will give us myopia. I stay with you. So take the astigmatism of the autorefractor because it's accurate, but not the sphere. The sphere is usually more myopic, and you can easily find the emetropia with a duochromatic test, red-green. Maybe it's also affected, but it's easy. It's easy. But astigmatism is reliable. Sphere, no.
With that, usually the intensity of the pentafocal IOLs-based refractive powers are intended to more myopic targets. So maybe the pentafocal, the intensity have more myopic results with autorefractive compared to other conventional diffractive IOLs.
Okay, can you put my slide on? Yep. I just want to show one of my case. Give me a pointer. Light. Yep. Yeah, one of the case, the both side 0.4 vision, and the nucleus sclerosis is around 3 degree, and you can see the auto-refraction, minus 3.0, both side. Okay, and here is the lens degree. And first, this patient just want to use the toric platform IOL in the first eye. And I will do the pentacan to see the co-alpha, co-mu, and to see the Z40 to check the spherical aberration for this kind of patient. Because the first eye, he want to do the toric IOL. Excuse me. And I use Hanita toric, okay? In the first eye, left eye. And after the toric IOL, he got good result for far vision, but he complained about near and intermediate is not so well. So the second eye, right eye, I designed to put intensity for this patient. Okay, but you can see not so function. Okay, check the pentacan again. Not so many astigmatism, and co-mu, co-alpha below 0.5, and the spherical aberration is low. So I decided to put the pentafoci intensity. And the A constant is 118.4, just like our Arcon SA60AT. And I put the intensity pentafoci, you can see that I used plus 30.5 diopter, and you can see the final result. Implantation is easy, just like other intraocular lens. But he got the like Bonnie haptic. So you need to put the back haptic into the back. Use your Zinsky hood other instrument. Make the full haptic in a proper position. And you even can see the ring very clearly, right? This is the intensity lens. Okay. So the final result, like Dr. from Korea and the Italy doctor said that you need to give some minus in right eye, and left eye is the toric platform, and only use one eye. It's really great that patient can see near J1.
你从这边念。好，以经道之事，又坚持这些。
Sorry, he speaks Mandarin, not English. But he can just read the Neo chart smoothly from the lower part to the upper part. I just test every case, my patient, to see the implantation result. So you can see online, they can see very well.
这上面是生活之道如何。
Okay, so this is intensity result. So I think this is really convincing and believing that you can use this kind of IO to your patient for far, intermediate, and near. Thank you very much. Yeah, so no question. So we have to close our section, proceed to next one. Thank you very much.